Thank you, Van. That was a great talk. Really appreciate it. It is now my pleasure to invite Dr. Satya Das up to the stage. Dr. Das is also a medical oncologist and a GI oncologist at Vanderbilt University. I just learned this morning he also has a connection to Memphis, in that his in-laws are from Memphis. So if you like your in-laws, we were very happy to invite you here, but we apologize if you don't. Anyway, please, Dr. Das.
Thank you so much. It's a pleasure to be here, and thanks to the organizing committee for this opportunity. We'll keep my in-laws out of it, so just to be politically correct. Great. So I'm going to be talking a little bit about the evolving role for immunotherapy in upper GI malignancies, as well as updates in neuroendocrine neoplasms. I'm a GI oncologist, as Dr. Vanderbilt mentioned. I focus on neuroendocrine tumors and upper GI cancer. These are my disclosures. Brief roadmap for the talk. I'll be starting on immunotherapy advances in biliary cancer that were recently presented at GI ASCO. We'll then move to the evolving landscape of immunotherapy in gastroesophageal cancer, then transition to novel treatment approaches for neuroendocrine tumors, and finally touch on some novel treatment approaches for neuroendocrine carcinomas with the point of distinguishing between those two entities. So with regards to the rationale for immunotherapy in biliary tract cancer, we see that from broad-spectrum genomic sequencing studies, a non-trivial subset of biliary cancer expresses signatures of elevated PD-L1 expression as well as T-cell infiltrates. This was carried to fruition actually and presented earlier in GI ASCO 2020 by Owen colleagues who looked at the addition of basically durvalumab, the PD-1 inhibitor, or durvalumab plus tremelimumab to gemcitabine and cisplatin, which has remained the standard of care in first-line unresectable or metastatic biliary tract cancer. In that small study, the progression-free survival seen with the addition of durvalumab was 11 months, and the overall survival approximated about 20 months. So based upon these findings, a subsequent phase 3 study was initiated. So this is the Topaz 1 trial that we'll be discussing in the next few slides. This was, again, data from colleagues of O et al. So this is a study designed for Topaz 1. It was a double-blinded, multi-center global phase 3 study in which patients with biliary cancer from any location who were untreated and with either metastatic or unresectable disease were randomized in a 1-to-1 fashion to durvalumab plus gemcitabine and cisplatin up to 8 cycles, followed by durvalumab maintenance every 4 weeks, or gemcitabine, cisplatin, and placebo maintenance until progression-free survival. The primary objective of this study was overall survival. Key secondary objectives included progression-free survival as well as efficacy by PD-L1 status. So the main upshot from this trial is that the primary endpoint of overall survival was met. And this is quite remarkable because for the first time in biliary tract cancer, we have an agent that has been added to gemcitabine and cisplatin that has successfully prolonged overall survival. While the median overall survival benefit was quite modest, was about 1.3 months, the hazard ratio of 0.8, what we see often, as in many of these immunotherapy studies, is the tail of these curves. So the 2-year overall survival in patients that were treated with immunotherapy plus gemcitabine and cisplatin was 25% compared to 10% with gemcitabine and cisplatin alone. With regards to key subgroups, irrespective of where the tumor was located, patient age, and location, we see the benefit for the immunotherapy plus gemcitabine and cisplatin arm. Notably, however, the subgroup at the bottom, which was PD-L1 expression, which was measured by total area proportion, akin to a CPS score, there was no benefit seen in patients irrespective of PD-L1 expression. So my takeaways from this study were beyond overall survival benefit. We saw a progression-free survival benefit as well with the addition of immunotherapy to gemcitabine and cisplatin. Quite notably, there was no difference in treatment-related deaths, grade 3/4 adverse events, and general serious adverse events, suggesting that this is quite a tolerable regimen. And in my estimation, gemcitabine plus cisplatin plus durvalumab represents a new possible standard of care for this patient group. And again, we see the true benefit at the tail of the curves rather than the absolute median survival benefit. The next group of studies that I wanted to focus on were the updated results from Checkmate 649 and Keynote 590. So Checkmate 649, as we all know, is a randomized global phase 3 study. It was a 3-arm study in which patients with untreated gastric, gastroesophageal junction, and esophageal adenocarcinoma patients that were HER2 unamplified were randomized in a 1-to-1-to-1 fashion to oxaliplatin-based therapy, in this case Folfox or Zelox, the addition of Folfox and Zelox plus nivolumab, or another experimental arm of nivolumab plus ipilimumab. The primary endpoints of this study were dual, looking at overall survival and progression-free survival in patients with CPS scores greater than or equal to 5. And there were hierarchical analyses if these endpoints were met, that secondary endpoints looking at overall survival in all randomized patients, patients with CPS scores greater than 1, and some of the other endpoints as mentioned. So this is the 24-month updated results from this analysis. This is looking at all randomized patients. We see that in the all randomized patient population, overall survival was maintained. We see a median overall survival of nearly 14 months in the patients that were treated with nivolumab plus chemotherapy compared to 11 months in the chemotherapy alone arm with a statistically significant hazard ratio of 0.79. And progression-free survival, though a more modest median PFS benefit, again, we see a statistically significant hazard ratio also in the 0.7 to 0.8 range. An important secondary endpoint that was provided here was progression-free survival 2, because naturally the thought is that perhaps patients who didn't get immunotherapy in the frontline setting may get immunotherapy in the later line setting. In this trial, progression-free survival 2 was also statistically significantly improved in favor of the nivolumab plus chemotherapy arm at 12.2 months versus 10.4 months. There were some interesting findings, however. Previously, pembrolizumab was approved for the third-line treatment of PD-L1 positive gastric and gastroesophageal adenocarcinoma patients. However, that approval was pulled by the FDA. And perhaps that can explain by when looking at the numbers of patients who got subsequent immunotherapy, it was quite low. And this may have had some impact on why we saw a progression-free survival 2 benefit maintained, because the patients who didn't get immunotherapy early on never got immunotherapy. Now, this is sort of an area that's still controversial, and I think it begs a lot of debate in the field. But in what patient subgroups of PD-L1 was overall survival maintained? So we know that overall survival was maintained in the primary endpoint group, which was patients with CPS scores greater than or equal to 5. But there were some nuances. The assay that was used to measure PD-L1 in this study was a little bit different from what's commonly used. So the DACO 28-8 assay was utilized for this study. 60% of patients had CPS scores greater than or equal to 5, which is higher than what's been reported in real-world evidence. Many of CPS scores are defined by the Ventana assay, the 22C3. So there are some questions whether the disproportionate expression of PD-L1 by assay influenced the results. But what we see here from overall survival as well as objective response rate is that patients with higher degrees of PD-L1 CPS expression, greater than or equal to 1, greater than or equal to 5, greater than or equal to 10, experienced more deeply profound responses, as well as increased overall survival. Now, to this very point about how much of the benefit was driven by the CPS greater than or equal to 5 subgroup, there have been some subsequent advanced statistical studies that have been published. This was one that was recently published by Zhu et al. And JCO, looking at Kaplan-Meier subtraction techniques to actually look at patients excluding the CPS greater than or equal to 5 patients and looking at only, for example, CPS 1 to 4 patients. And interestingly, in this analysis, there was no difference between the immunotherapy plus platinum doublet group or platinum doublet group alone. But again, this was not prospectively derived studies. These are retrospective statistical techniques. So my takeaways are that the overall survival was maintained in patients with longer-term follow-up with esophageal, gastroesophageal, and gastric adenocarcinoma patients. In my estimation and in my personal practice, I do offer nivolumab to Folfox plus Capox, but only in patients with some degree of PD-L1 expression. I'm still using a CPS score greater than or equal to 1. However, it's still remains to be seen whether that will ultimately be the takeaway. And the higher the CPS expression, the more pronounced the responses. So with that, I'll shift to the Keynote 590 study. This was a different patient population. So this is a global randomized phase 3 study looking at patients with esophageal cancer, both squamous and adenocarcinoma histologies, and randomizing patients to pembrolizumab plus chemotherapy, which in this case consisted of fluorouracil and cisplatin. The cisplatin was capped at 6 cycles, versus placebo plus chemotherapy. So with the baseline patient characteristics, I just wanted to highlight that this is a very different study than the Checkmate study at 649 that I just discussed. 75% of these patients possessed squamous cell esophageal tumors, which was a histologic group that was not included in the Checkmate trials. So looking at overall survival and progression-free survival, after 12 months of longer-term follow-up, we see statistically significant maintenance of overall survival and PFS with hazard ratios of 0.73 and 0.64, and prolonged benefit looking at the tail of the curves. Pre-specified subgroup analyses of overall survival were also conducted. So looking at the esophageal squamous population with elevated PD-L1 expression, CPS greater than 10, we see a hazard ratio of 0.59 in benefit of the chemoimmunotherapy arm. In all squamous cell carcinoma patients, we see a benefit in favor of the chemoimmunotherapy arm with a hazard ratio of 0.73. And furthermore, in all patients with mixed histologies with CPS greater than or equal to 10, we see a benefit, a hazard ratio of 0.64 in benefit of the chemoimmunotherapy arm. So my takeaways from the Keynote 590 study is that after 12 months of further follow-up, overall survival and PFS benefits were maintained in patients with esophageal cancer. No excess toxicity was observed with the experimental arm over platinum doublet chemotherapy. And I think it's very important to distinguish histologies here because esophageal squamous cell cancers, for patients with those histologies, platinum doublet with cisplatin 5-FU and pembrolizumab is a potential standard of care. However, for adenocarcinomas of the esophagus down, I think either platinum doublet plus immunotherapy can be utilized. So with that, I'll transition quickly to updates in neuroendocrine neoplasms. This is just a brief image of where seeing is believing, in that one of the biggest advances that's been made in neuroendocrine neoplasms is the adoption of improved somatostatin receptor-based imaging. So on the left, we have a small bowel NET patient that was imaged with an indium-111 Octria scan, and the same patient on the right being imaged with a copper dotate scan. One of the other big advances in neuroendocrine neoplasms has been actually classification. So as odd as this sounds, for many, many decades, we were not able to separate neuroendocrine tumors from neuroendocrine carcinomas. And furthermore, any patients with a Ki-67 of greater than 20% were previously considered neuroendocrine carcinomas. However, this has been changed. In 2019, the WHO adopted a whole new classification looking at the well-differentiated grade 3 neuroendocrine tumors, which are tumors with a Ki-67 of greater than 20%, but still with well-differentiated histologies. And this is a very different tumor entity from what we see in other settings. So with regards to neuroendocrine tumors, what are some of the emerging targets and opportunities? So vascular endothelial growth factor tyrosine kinase inhibitors, a number of novel VEGF TKIs are being tested. This is data from a drug called surufatinib, which blocks multiple VEGF receptors as well as CSF1R. This was 2 Chinese phase 3 studies looking at surufatinib versus placebo in pancreatic NETs on the left, SANET-P, and extrapancreatic neuroendocrine tumors on the right. We see progression-free survival was the primary endpoint and was highly statistically significantly improved in both groups treated with surufatinib. Now, this was a relatively treatment-naive population. 30% of patients actually had no prior lines of therapy. So based upon this Chinese data, this is the first VEGF tyrosine kinase inhibitor that's approved for non-pancreatic neuroendocrine tumors globally. The FDA is currently viewing data, some of which was collected from colleagues like Arvind Dasari at MD Anderson, and is actually expected to rule hopefully favorably on this drug in the next few months. What about another VEGF tyrosine kinase inhibitor, Capizantnib? So Capizantnib is a drug that blocks VEGF receptor 2 along with MET, as well as other targets. It's shown efficacy with regards to response rate and prolonged PFS in 2 phase 2 studies, which have led to the global Cabinet study. So this is a randomized phase 3 study in pancreatic and extrapancreatic neuroendocrine tumors, randomizing patients in a 2-to-1 fashion to Capizantnib or placebo. In this case, several amendments have been done to facilitate accrual. No longer is everolimus exposure required, and now crossover is also allowed for equipoise for patients. So what about some of the emerging targets? And I'll wrap up in the next few minutes, but one of the major cornerstone therapies for neuroendocrine tumors that was approved in 2018 is Lutrisium Dotate, or peptide receptor radionuclide therapy. We know that Lutrisium Dotate elicits its maximal effect by creating single-strand DNA breaks. So they are, and while the progression-free survival benefit is striking, the response rate is quite modest. It was only 18 to 20% in the Netter study. So there are a number of novel approaches looking to combine agents to enhance the creation of double-strand DNA breaks in addition to Lutrisium Dotate. Some of these ongoing studies with patients with gastroenteropancreatic NETs include the addition of triapine, which is a ribonucleotide reductase inhibitor, the PARP inhibitor olaparib, and the DNA PK inhibitor pepasertib. So these are all studies that in the next year to 12 months, we anticipate getting phase 2 data and potentially moving forward against lutetium. So what about neuroendocrine carcinomas? We know that in the last 3 decades, drug development has been barren in this space. And so one of the exciting approaches is looking at the addition of immunotherapy to platinum etoposide. We know that from the Empower 133 study, atezolizumab plus platinum etoposide has become a frontline treatment standard for small cell lung cancer. But the question is, can this also be translated to extrapulmonary neuroendocrine carcinoma, and in particular, extrapulmonary small cell? So this is a randomized study looking at platinum etoposide versus platinum etoposide plus atezolizumab versus a very interesting arm of platinum etoposide plus atezolizumab with atezolizumab maintenance, seeking to answer 2 questions. 1, is atezolizumab, the addition, going to improve survival? But 2, is maintenance necessary? Another area or avenue of exploration in neuroendocrine carcinomas is looking at targeting DNA damage repair. So this is a phase 1A, 1B study that we've been fortunate to help lead, looking at the addition of topoisomerase 1 inhibitors plus a novel ATR inhibitor called ilimusertib. So we have 2 dose escalation arms, topotecan or irinotecan plus this agent, and then are going to be expanding it out to expansion cohorts in small cell lung cancer, extrapulmonary high-grade neuroendocrine cancer, and pancreas adenocarcinoma. So the big takeaways in closing are that neuroendocrine neoplasms, the highlight and the most important thing is separating neuroendocrine tumors from neuroendocrine carcinomas in studies because of vastly different biology and vastly different behavior. We know that multiple VEGF tyrosine kinase inhibitors are in the pipeline and hopefully will garner approval for our NET patients. And hopefully immunotherapy's addition to chemotherapy in the frontline setting and some of these novel agents in the later line setting will help improve outcomes for our patients. So with that, I'll close. Thank you very much.